To be very honest, sometimes an orthopedist who's saying, I want to do hemophilia, you have to say, why would you do that? It starts that way.
And maybe I heard the word mentioned in medical school, but that's really all I know about it.
Hemophilia was a definition only, a bleeding disorder, and they didn't teach us anything about it in PT school.
It was kind of like this niche that needed to be filled, and I realized that I was very interested in it. That was the job I would like to do.
I learned about hemophilia really from scratch almost.
Hemophilia is a disorder in which your blood doesn't clot properly.
I had some of these patients on my schedule, and I began to know who they were and what the disease was all about.
It is like a super family practice where you get to know persons of multiple generations, brothers, cousins, aunts and uncles, and develop very close relationships with people over time.
I wanted to have that continuity of relationships with patients.
I really saw what I was doing a lot as community organizing.
And I somehow became psychologically, I felt responsible in a way that was probably quite unreal, but I still felt responsible.
I'm Carol Casper. I'm a hematologist.
My name's Everett Winslow Lovren, and I was the director of the Oregon Hemophilia Treatment Center.
I've been working with some form of hemophilia or blood coagulation for 49 years, I just figured up. I'm William Hathaway.
Over 50 years ago, I first saw my first hemophilia patient. My name is Shelby Dietrich.
I'm Marilyn Manco-Johnson. I'm a professor of pediatrics and the current director of the Mountain States Regional Hemophilia Center.
Professor of orthopedics, University of Colorado School of Medicine.
Jerome Weedle, W-I-E-D-E-L, go by Jerry.
Dana Francis, I'm a social worker with the Adult Hemophilia Program at UCSF.
I work at the Oregon Hemophilia Treatment Center. I'm Dave Olson, I'm a physical therapist.
My name is Marion Kerper. I'm a pediatric hematologist here at UCSF.
Susan Karp. I'm the nurse coordinator of the hemophilia program here at University of California at San Francisco.
I'm Mary Lou Damiano, and I'm the assistant director at the Hemophilia Center at the University of Arizona.
I'm Sharon Funk. I'm the physical therapist here at the Hemophilia Treatment Center at the University of Colorado in Denver.
It was only myself and sometimes a resident or sometimes a fellow. We didn't have a nurse or anyone else. It became obvious that in order to deliver the kind of care that the patients were asking for and to be able to plan it in a way that they could have total care, comprehensive care, we had to have a lot more people in the center helping us.
Comprehensive care really encompasses providing services toward patients' many needs.
Well, our team consisted of physicians, some nurses. We had a social worker, a physiotherapist, which is very important.
To have all of the components available in one place was a big step forward.
And the first thing I said was, I want you to be on the team, but you have to come to the weekly meeting. Communication, I knew without someone spelling it out. I didn't know it was communication, but it was essential that we get together and discuss.
A person with hemophilia needs to, number one, have a hematologist who knows what that person is affected with, all the considerations of that hemophilic condition in that individual. And I've always said, the person I contact first on every person who I see with hemophilia that I have a question about is the nurse.
Most of us never received any hemophilia training in nursing school, and I think it was because none of the instructors in nursing school knew anything about hemophilia. So almost all of us were trained by the Hemophilia Treatment Center director, who was the hematologist. So we learned more kind of medicine of hematology rather than nursing of hematology. So we were kind of the jacks of all trades.
It's ever changing, and that's what's so exciting about it. And you know, the continuity of working with some of these patients over many, many years. I have a couple of adult patients that I've known since they've been in utero. I have any number of adult patients. I always joke and I say, I've known these guys since they've been shorter than me. And, you know, it's just, it really is very fulfilling to work with people and develop that relationship.
You don't see the patient just once, you see them over and over again over a period of time, so you get to know them. Furthermore, people suffer and you can relieve suffering.
Physical therapy involvement in a person with hemophilia, I think, is critical.
Little by little, the therapist that was identified as the treatment center therapist began to see all of the patients.
My training really was multifaceted. I got a lot of help and support from the other people on the treatment team.
We became very familiar with how the disease worked and what worked in physical therapy and what might not have been as successful.
I would learn when to intervene, when to back off, how to intervene, what would make it worse, what would make it better.
And I think that made a huge difference in how care was provided. The patients had faith in us, that we knew a little bit about the disease, that we were going to try not to make them bleed, and hopefully we would help them get over a hurdle and maybe become stronger and get better range of motion.
The people who really you're taking care of, they're your patients. You get to know them on a different level.
And I think that trust that the patients developed in the therapists who have stayed with the programs is irreplaceable.
Our social worker in particular helped families to get qualified and get onto the California Children's Service Program. And again, meaning that the father could go to work, could get insurance, they didn't have to live at a poverty level in order to be eligible for Medi-Cal. They could work, and so their family could have a better lifestyle, a better standard of living, and their child could still get their really good hemophilia care that they needed.
That's a really effective way for patients with hemophilia to get taken care of in a very holistic way. It's one-stop shopping, and it's a great way for people to get their needs met and get all kinds of referrals if they live far away to kind of keep body and soul together when they're not here.
The families certainly early on were very appreciative because they had never had services like this and they never had really continuity of care.
The format for looking at the patient as a whole person, or the child, and the parents, of course, and trying to understand and approach all the problems.
If you've never seen really bad joint disease or you've never seen a bad bleed that's out of control, it's easy to become complacent and think that, you know, this isn't any big deal.
I remember in the early days the deaths more memorably because we had so many.
Beginning very young, 2 years wasn't unusual. Very frequently 4 or 5-year-old boys that had very, very advanced bleeding problems already in their joints.
By the time the guys reached their late teens, they probably had multiple joints involved, probably all 6, the elbows, ankles, and knees, both of them, and maybe even some hip and shoulder problems as well. The disease definitely impacted every aspect of their life.
When I first started, kids were on crutches, multiple kids were on crutches. I was making casts, I was making splints, I was treating bleeds.
They couldn't go to school. If they were out of school, they couldn't hold a job. They had chronic pain. They couldn't do any of the activities that their peers did. They could not go to camp. They couldn't go skiing. They couldn't do anything.
Dentists wouldn't see a patient with hemophilia. They didn't have time to attend them in their chair during the time that they required.
And my first exposure was a family with 4 boys, of whom 3 had severe hemophilia, and would come to the emergency room to get cryoprecipitate, which took anywhere from 2 to 3 hours to thaw, pull, and infuse through an IV drip. And with 3 boys, little active boys with hemophilia, this family spent easily 3 or 4 nights in the hospital of every week.
Our patients had to pay for their plasma themselves, or their families had to pay for it. Insurances generally did not cover blood products, including plasma. Dr. Dietrich managed to get hemophilia covered for children by the state program in 1968, I think it was.
So into this picture came a wonderful boy, 16, named Sean, with acute appendicitis. And there was no question medically that he had acute appendicitis. You couldn't call it anything else. So the surgeon, the general surgeon, operated on him, and everything went fine for about a week, and we thought we were out of the woods. And then we ran out of concentrate, and he had to go back to plasma. And he rapidly became very ill. He was obviously bleeding in the abdomen, in the intraperitoneal space. And I remember sitting up all night with him. We pumped everything we had, including blood in, but nothing helped, and he died. And I'll never forget that. And I'm sure that bitter scene is repeated everywhere in the world where patients get appendicitis or whatever and die because the bleeding can't be stopped, and that is really a dreadful death.
It was sad to see that type of involvement. And then we saw the other spectrum, the adult who now had survived all these years with these recurrent bleeding episodes, had these terrible joints that were deformed, restricted in motion, and very painful. This was the scene when I first started in '74. We saw almost every person that came into that clinic was that way, either the young one or the more advanced age. And advanced age in the hemophilia, we're not talking 70, 80-year-olds, we're talking 30, 40-year-olds.
Complicating factor today is the inhibitor population. They are always there to remind us of what hemophilia can really be like when it's not treated as effectively as it needs to be.
Home treatment programs were set up, education of the patients and parents to allow them to get factor replacement early with their first joint bleed.
And home treatment plus a world of surgical procedures became possible. Then that was the most dramatic change in hemophilia over the 50 years. It changed it from the Dark Ages to enlightened treatment. What we found in Japan was almost unbelievable. At least I was very naive. I had never been to Japan. And they didn't have home treatment. And their head doctor looked at me and said, "You really let these patients do that at home?" I thought maybe he was talking about sex, but what he was talking about was intravenous concentrate.
Initially, no one did surgery on these patients. They had a lot of hemophilic arthropathy. They weren't working. They spent probably 60% of their time in the hospital being admitted as inpatients. So to have them be able to treat at home and actually go to school and work and not spend so much time in the hospital and also have their knees repaired and their ankles repaired was a totally life-changing experience for the patients.
But as soon as concentrate was available, we started home treatment very early.
First patient was around 1968, and then by about 1970, we were training people generally. The big advantage of home treatment was that patients could nip their hemorrhages in the bud. They recognized early that they were bleeding and they could stop it at home.
We had a weekly meeting of all of our hemophilia staff. Every Friday morning at 10 o'clock I would ride in with my bicycle with a box of donuts on it, and we would all sit around and drink coffee and eat donuts and talk about all the telephone calls, all the contacts we'd had since the last Friday, and then we would decide who we would recommend should be started on home infusion. And of course, most of the families were anxious to do that. And so then we would bring them in for a training session. Usually it takes 6 sessions to teach them all about safety, to avoid infection. We'd begin by having them actually infuse a butterfly needle into an orange so they could get used to using the needle, and they would have the families practice on us and decide when they were able. We would call them graduate and go home.
This was not only good to get the hemorrhages stopped quickly, but also it meant that their personal lives weren't being interrupted so much, that they were able to stay in school or stay in work, or go on a vacation even. That was a big advantage. Patients started to become quite independent.
So it was just really exciting to be able to do these things, to teach them these things, to get them on home therapy, and really make a difference in their lives. It was like addictive. I mean, once you got started on it, it was like, man, this is so great.
When you're dealing with a chronically ill population such as hemophilia, and especially with a population that is doing so much self-care at home, that the more they know about their disorder and its management, the more successful they will be in managing it.
By putting them on home therapy and prophylaxis, which we actually did some of even back in the late 70s and early 80s, the families knew that the child got his dose in the morning, then he could go to school and be fine, and the mother wouldn't have to worry that she might get a call at 11 to go pick up the kids. So then she could get a job as well if the family needed that added income.
You can't overlook those advances and say it was only a physical thing. Families were freed, family life improved, the patients immeasurably were healthier physically, and as important, they could go to school and they could hold jobs.
A lot of families actually discouraged any kind of physical activity in their children. Children weren't allowed to participate in physical education at school, and they certainly were not allowed to participate in sports. So that's become a whole new emphasis in the Hemophilia Treatment Center. We're really emphasizing making sure children are not overweight and keeping them physically active, and emphasizing that they can participate in sports with a little pre-treatment or by being on prophylaxis. So prophylaxis and home treatment has definitely revolutionized pediatric patients' life choices.
Young boys with these terrible swollen joints from the recurrent bleeding were no longer coming in because they were not there. These boys were starting to lead a pretty normal life. I mean, they were doing certain sports that they could do because they were given factor to prevent the bleeding. When they did have spontaneous bleeding, they had early treatment. And so we very soon, within years, say a decade after I started in this, we were not seeing those young boys with these terribly involved joints. So we were not, at that stage, now having to perform these invasive surgical procedures.
So we saw a great increase in life expectancy. We saw that intracranial hemorrhages were no longer universally fatal. We saw that people could undergo surgery, like have a joint replacement or reconstructive surgery. They could have an appendectomy. We even had open heart surgery on one patient. And that was a great achievement, to be able to, of course, relieve suffering so that people didn't lie awake in bed all night in agony. Instead, they found relief from infusion, so that was a great improvement.
Our goal was really to start normalizing life for people with hemophilia and families with hemophilia. The social worker did a lot of work as far as talking to families about how to normalize their life and how to work with the kids and, you know, treat their kids like normal kids who just happen to have hemophilia.
Summer camp was sort of a byproduct of that. So the older generation had a lot of joint deformities, using crutches, were needing joint replacements. They didn't want the younger generation to grow up the way they had, and they saw camp as a place where the kids could learn to take better care of themselves and hopefully not end up with really bad joints. So the community really came together in a major way. It's like we bring the treatment center to camp. And so it's been good for the families to be able to let go and let the kids be away from them for a week. And it's been good for the kids to realize that they don't have to be, stuck like glue to their parents all the time.
Really what's different in hemophilia, where I see it a lot, is at camp. I see the kids now and what they're able to do, and how they're running around. Their mobility is so much better, and there's a lot of the older guys, our staff and counselors with hemophilia, and they're always amazed at what the younger kids can do. Personally, I'm amazed at what the older guys can do. They're a very inspiring bunch of people.
And one of the important things we do at camp is teach the kids how to stick themselves so they can treat themselves. So as they get older, they can think about going to Boy Scout camp or music camp, or going abroad and being a foreign exchange student, going away to college. It sort of opens up new doors for them that they hadn't considered before.
My name is Chris Bombardier, patient here at the Hemophilia Center in Denver, Colorado, 23 years old. I have a severe factor IX deficiency. Coming here since I was born. I don't even remember the first time I was here, but I've been here at least once a year for my entire life. When I started playing baseball, my parents just thought it'd be kind of a thing to do when I was young. And I just developed this passion for the game and wanted to play it every second of my life. And when it started getting more competitive, I started having more bleeds, and the Hemophilia Center was really great about not saying I couldn't do it, but supporting me and, just working through the problems I had. The first few years of competitive baseball were really tough because I didn't infuse myself. I was kind of relying on the treatment center to do it, and eventually they taught me how to self-infuse, and it really, helped me get through that whole period. And now infusing is like nothing to me. It just comes naturally.
To go to hemophilia camp was to see what kids with bleeding disorders could do and not bleed, because you have the feeling that no matter what, any kind of movement, any bump, any fall, it's just going to be a big disaster. And then you see the reality of it, and it was very soothing, very calming. That be pretty much normal kids and get to do stuff. That was good.
I guess maybe in the back of my mind I knew, maybe I shouldn't jump off this thing or do something like that. But I never really thought it was different, and I think that was kind of the goal of the treatment centers, to make you feel like a normal kid and just go about life in a normal fashion. I really felt like hemophilia has held me back from any one of my goals. My goal was to play college baseball, and I got to do that.
Just being able to have a normal lifespan, that's a good thing. It's something that you take for granted unless you have something that doesn't allow you to have a normal lifespan.
Improvement of a lifestyle, improvement of the health of these individuals, which is in turn reducing the cost of health care for these individuals.
I think because of the long-term nature of our relationships with them, we just have this opportunity that most people in medical settings don't have, where we get to know someone over their lifetime. And one of the barriers I felt when I first came into the work was that there had been quite a bit of turnover. I think the issues of HIV, particularly in hepatitis, really affected the professional social workers too, and a lot of them were kind of freaked out about how am I going to deal with this.
The development of HIV, which was totally unexpected, unknown, and a major disaster as far as the hemophilia population was concerned, this was a whole new problem to deal with, areas that none of the people in hemophilia care were really equipped to handle. It was a whole new ballgame, really.
We had scarcely recognized what AIDS and all that was, because it wasn't even described. There wasn't even a real vocabulary. So on one hand, we had a huge advance that changed life for all hemophiliacs, and then we had a huge setback that equally, in a disastrous way, caused many of them to have fatal illnesses.
I didn't go into medicine to help people die. I went in to help them live a better life, and I was helping people die.
It came on very suddenly, it seemed, and it created a lot of sick people, a lot of deaths. We were very busy taking care of the patients who were infected.
In May of 1982, giving a lecture somewhere and saying, you know, I have the greatest job in the world. You know, the child, we make the diagnosis, then we say, but you know what? It's going to be fine. We're going to give you this concentrate, you're going to go home and you're going to treat your child at home and everything's going to be fine. And 2 months later, the first 3 hemophilia patients with AIDS were reported in the MMWR. For the next about 7 years, the social worker in particular really had his or her job cut out for him.
I mean, I couldn't make any promises and I didn't know what was going to happen, but I really felt a lot of kindred spirit with these guys around the struggle that they had, and I felt very compelled to want to work with them and be a part of that.
I think that the patients began to think of the Hemophilia Center as the place from which they got the products that infected them. And certainly on a national basis, there was a pulling away from hemophilia centers and hemophilia doctors who were often being blamed for the AIDS epidemic.
All medicines have hazards, and we assumed that the benefits were greater than the hazards, and that turned out not to be true because since that time, many patients who have survived HIV infection have died of liver disease, including cancer of the liver. So I have great regrets about that. I regret that we didn't know more about HIV.
It was the most difficult time professionally in my entire 50 years of medicine. There's no question, because there was no good answer whatsoever.
No, but it was a very intense time.
The question is, what should we remember? What should we not forget, basically, from what we learned in those early years to carry on into the future?
You need to make a specific diagnosis, organize the care carefully so that it addresses all the problems, and work towards the most specific treatment possible. I mean, you know, it's like utopia, but that can be done. That's the thing you shouldn't forget.
Early recognition, early diagnosis, getting individuals with hemophilia and other bleeding disorders into appropriate care, and probably at comprehensive centers where they're available, is still an important thing.
We're informed by our history, and I think it's real easy for these young families to think that you just order your factor and make sure your kid gets it 3 times a week and everything's fine. And it's not like I want people to dwell on the horrors of what their predecessors went through, but you can really, the hemophilia community has to be vigilant about the blood supply and about what's going on with their products. And I remember once at a symposium a few years ago, one of our community leaders asked the young families, he said, read everything you can about what's happened to our community. He said, put a stack of books next to your bed. And he said, take your time and read all perspectives, and you don't have to choose a position, just educate yourself, because do this for your child who has a bleeding disorder, because it's really important to know what happened and why it happened.
New generations, they have no idea, they have no concept of what life was like before factor, before prophylaxis, and before comprehensive centers. So we do have to, you know, sort of remind them that they've got to keep fighting for funding for the comprehensive centers.
It's important, I think, for all of us, no matter who we are, to remember what our roots, remember where we came from, not get above our raisin, as my mother used to say.
Just the normalization of life, the goal of normalizing life for people with hemophilia and families is important to remember even today, I think that hemophilia has become such a manageable chronic disease that people forget that during the early years it wasn't, and that the struggles that we had with normalizing life for people, and that still needs to be an important goal for hemophilia care providers.
It's hard for me to say. From the point of view of the Hemophilia Treatment Center, I think just continuing and being better funded. Scientifically, of course, the challenge is better treatment with a long-acting or an oral concentrate or improved treatment of that sort.
Really, I think I would think on a very grand scale, as the Cystic Fibrosis Group did about 10 years ago in terms of, and the National Hemophilia Foundation, about thinking of a cure. If we were to get a cure, what would we need in terms of the research elements, the funding, the access to information and communication with patients for enrolling on clinical trials?
I'm not sure exactly what kind of doctor I want to be, but I know I want to be involved in the hemophilia community in some aspect, whether it's being a hematologist or just being involved in the community. I want to definitely stay involved with this whole center.
Time I've spent dealing with hemophilia with patients, with families, has certainly been a rewarding one.
So I really feel like I see the whole spectrum of these patients, and it's a nice long-term relationship with them.
I feel like I'm sort of been part of the family. I've watched these kids grow up.
As their doctor, you become part of their lives.
The struggle and the growth that these families have gone through, overcoming the confusion about where do we fit into this picture.
You need to have somebody who's totally interested in the family and the patient, not just the disease.
The result of that, we see patients that are living really relatively normal lives.
You make a difference in their lives, a huge difference in terms of how they are living with and coping with a chronic illness.
Baseball, be a normal kid, I'm skiing, I go rock climbing, I do all these things, and they just let me do them because they know I have the support here.
The contributions that different people with different types of training can contribute. You don't choose to work in hemophilia, hemophilia chooses you.
Relationships among a comprehensive team and with the families, not being so much the subject matter of what you're dealing with, just accepting that constantly changes and evolves, and we just grow and step up to the plate to deal with what we're handed.
There's a community spirit in the hemophilia community.
One comes to know the family as a whole, and it's like a story. It's like an epic.
I saw in them such frustration, but such a determination to go on in life. That's really what I saw, was this, I'm going to live determination and do something. And I guess that's what hooked me.